When I started my general practice training, I was trained to detect depression and make the diagnosis and give antidepressants. There was not very much counselling and therapy around in those days. But actually the guidelines now are even clearer, that we just have to elicit the symptoms, make the diagnosis, and either give antidepressants or CBT. We can do all of that without any relational work, without thinking about the individual, and dispose of the patient in a very mechanistic way. But in the last 20 years of working with patients, and particularly working in the Icebreak team, where I see young people with an extraordinary array of problems, but also a fantastic set of skills to deal with these problems that they've developed because of the appalling things that have happened to them and the opportunities they've taken to deal with their distress. But this group of young people have a range of problems that could be seen as symptoms from 10 or so common mental health problems and more severe mental health problems. They might have voices, they might have OCD type compulsions, they might have episodes of what we call derealization, where they don't feel the world is real. They can have flashbacks and they can have voices. All of this alongside periods of low mood and intense depression, or anxiety that's with them nearly all the time, or moods that are fluctuating rapidly from high to low to anger. So given the range of symptoms that are presented, I've realised that the diagnostic criteria or the diagnostic system doesn't work anymore for this group of individuals, because people can be said to have 2 or 3 so-called disorders, or they could have none according to the criteria and yet have a set of problems that you or I would find incredibly hard to deal with. So I've stopped believing